Okay. Good. Hi, everybody. My name is Tanuj Gupta, and I'm with Cerner Corporation. I'm in the Population Health Division under our Clinical Intelligence Group. There's a lot of people from Indiana here, so my boss is Mark Overhage. Folks from Regan Street might recognize that name, but you don't get Mark today, you get me. So assuming we do. There was some very good dialogue in the last panel, specifically around how do we get it into workflow, how do the vendors help. So I'm hopefully here to answer some of those questions. What I will do is talk to you about 11 ways we have been thinking about getting social determinants into the workflow through the technology. I'll talk to you about the 3 that I think we see as the priority, if you had to pick 3 to focus on. And then if we've got time, I'll talk to you about a demonstration project in Nevada, Missouri, where we did change the trajectory of that community, and we're continuing to, largely based on social determinants, and I'll tell you exactly what we did, how we did that. Fair enough? Okay, good. So let's go through 11 ideas here. So in the first bucket of capturing data, there's 2 ideas here. One is screening tools, which we've been hearing about already. How do you capture data on the individual? Somebody raised that question, so that we can assess the social determinants on that person. There are 20 questions in the EHR certification regulations. They're the IOM social determinants questions. They're linked to LOINC. So every EHR vendor should be incorporating that into their technology as a start. We are looking at the Prepare tool as well, but there are plenty of other instruments. So not only do we should look at multiple screening tools, but then how do you map them to a common framework? So that group that is meeting on Thursday, hopefully we'll get to some of those common standards. In the second project in the capture data space, again, it was talked about already, how do you integrate more large national databases, open data sources into your data sets so that you can look for insights there. So it's been addressed. I think a lot of people understand that one. But another big project. In the analyze data bucket, there's 3 projects that we're thinking of so far. One is a common one, is hotspot analysis. So can you look for areas that have high medical costs and correlate it with unmet social need and look for hotspots there. The second one is incorporating social determinant features into risk prediction algorithms. So can you stratify or predict risk, including these social determinant features in your models? Third one in that space is impact analysis. So can you, once you have intervened with a social determinant or you've referred to the right social service provider, can you understand the impact, whether it had any impact or not? Part of this to me ties to the community health needs assessment. So right now, a lot of health systems spend a lot of money on consultants to build that CHNA, and then it's already 12 months dated, and they don't do it again for 3 years. And if you are intervening with a social determinant intervention, you want to course correct faster. Ideally, you can speed up even just a CHNA, if not add more to it. So, and I'm not talking about real time every 30 seconds, but even if every 6 months you could do a CHNA using technology, it might be better for health systems. Now we've got 6 ideas in the integrate into workflow area. So one we saw with Ross's presentation is the display. Can you simply just display the social determinants for an individual in the workflow? So there's ways to do that are smart and that aren't overwhelming. Second is, and I call it technology because it leverages technology, but if you're doing these screening tools, assessments, can you link goals and interventions to those assessments? But just asking the questions is not enough. What do you do after that? It's really a content play, but for vendors like us, if somebody has done that work and said these are the right goals and interventions based on these questions, then we would build the pipes to deliver that into the workflow. Same goes for educational material. So it's not the same to deliver a brochure on domestic abuse to somebody through a portal. There's some rules and there's some nuance around that, but the technology can help if that content exists. Another is e-referrals was mentioned a couple times. So this one is, can we facilitate non-medical referrals, which largely follows the process of medical referrals, but there are some differences. So for example, for eligibility checking, you're not necessarily checking against the payer, but you might be checking against the service provider, whether they can accept somebody of your income level or veteran status. We've got integrating problems, social determinant problems into the care plan. So can the problem list expand beyond medical problems to include food insecurity or something, which are then linked to goals and interventions. So in the workflow, we should be able to include social issues into the plan. And then the final 11th one is just decision support. So a little different than risk prediction algorithms. This is prescriptive algorithms. So I know what my current state is. I know what a future risk is extrapolated from the current state. What should I do to mitigate that future risk? So that's where the decision support rules come in. To me, the top three that give the most bang for the buck is screening tools to look for unmet social need, unmet social need. Second is the referral. So whether your health system creates its own interventions or not, if you've got a good e-referral system that closes the loop, you can get people the intervention they need. And then third is the impact analysis. So how do I know that referral benefit or not? In Nevada, Missouri, it was one of the poorest counties in terms of health outcomes in Missouri. Cerner went in 5 years ago to say, can we use our tools and try to change the trajectory of that community? I know I'm talking about tools, but to me, the secret in that community was not the tools. It was the on-the-ground work. And I think there's 2 or 3 things that stood out to me. We use the tools. We use the patient portal. We use some of our wellness tools. But number one was, how do you build trust in the community? And so it took a while. It took almost a year to build trust in that community. We didn't brand it with Cerner. We didn't brand it with the health system. It's not like consulting where we have a week to a month to earn your trust. It takes a year, and there was no way around it. Part of the way we did that is hired local people who, outside of the workday, were also ingrained in the community. Second was, how do you instill a sense of pride in that community so that if you were going to say, hey, if we do this initiative where everybody runs this 5K, it'll earn money for a park for the community or earn money for a food market. People won't care unless they care about their community. Some of the people we hired were also very passionate cheerleaders about Nevada, Missouri, and they were living in the community. And then third was obviously intervening with ways we can help them, but most of the interventions were social determinant-related interventions, addressing food insecurity and things like that. So it's funny to be talking about the technology and the tools, but I think the secret to changing the trajectory there was not the tools. It was this on-the-ground work. They changed their health outcomes. They improved their health behaviors by 54% from where they were at baseline. They improved their health outcomes by 24%. And then we're continuing to be in that community, and we're starting to look at other communities to do something. But hopefully that addresses some of the questions I think that were coming up is how do vendors get involved with social determinants?